Good evening, everyone. My name is Dr. Miranda LaBant. I am one of the naturopathic physicians at Brio-Medical here in Scottsdale, Arizona. We are an integrative cancer clinic, team of 5 physicians. And this evening, we are going to be talking about an incredibly important subject, breast cancer. Today's webinar is designed as a live Q&A. I know a lot of people already sent in questions, so I'm going to be going back and forth and answering as many questions as I can. This webinar is designed to engage you. So I want to be able to, again, answer as many questions as possible so that each and every one of you can be empowered in your care moving forward, whether you are diagnosed with breast cancer or you have a family or loved one. As you can tell, I'm pretty jazzed about this subject today. I've got my hot pink on, kind of support the tatas. And so, the purpose of today is to really dive into the hope and healing and understand what is possible with integrative therapies. Back in the 70s, it was estimated that 1 in 20 women would be diagnosed with breast cancer. That's about 5%. Fast forward to today, it's about 1 in 8. That's about 13%. And that might not seem like a significant increase, but it unfortunately is. Further, it's been estimated that in 2023, approximately 30% of new female diagnoses with females will be diagnosed with breast cancer. That's about 1/3 of the female population. It's significant. And unfortunately, from a clinical perspective, I think we're going to be seeing more of this. It's the second leading cause of cancer death in women of all ages. So that's why we're here today, to take a deep dive, to answer questions that are on your mind. We do have the Q&A open, and my producer is going to be sending over those Q&A questions over to me as you send them in. But I am going to start with some of the questions that were sent over. So let's just take a deep dive in. I did notice that there were quite a few questions on triple negative breast cancer, rightfully so. It's one of the most challenging types of breast cancers to treat. If you're not familiar with triple negative, what that means is there are no receptors on the breast cancer cells. And so quite a few of the questions were asking, is there any new information or treatments on triple negative breast cancer? And what I will say is, yeah, absolutely. Even though this particular diagnosis comes with it tends to be pretty grim from the standard of care perspective. One thing I want to mention is that there are so many different prognostic biomarkers that can be used. And so I am going to talk about a few different treatment types. But normally with different types of cancer, there are certain biomarkers that can be used. And a biomarker is something that can show us more information, more characteristics about that particular cancer type. And so with triple negative breast cancer, there are specific biomarkers that we can use. A Ki-67 score. What this is something that can allow us to understand the proliferative rate of these cells. The higher that score is, the more metabolically active that is. So that's something we can look at. We can look at different mutations in TP53, which is a tumor suppressor gene. EGFR, which is a receptor, it's actually a family of proteins that have to do with blood vessel growth and formation, angiogenesis. All different cancer types use this process in order to thrive, to grow, to proliferate. And so with these different receptors, there are novel treatments that can be used. For example, if someone has a hyperexpression of VEGF with triple negative breast cancer, there's quite a few studies with the addition of bevacizumab, which is a targeted therapy. One thing that's not looked at, and I really want to emphasize this with triple negative breast cancer, is looking at androgen receptors. So when we think about breast cancer across the board, typically we think about estrogen, progesterone, HER2, and I'm going to talk about that in just a minute because we had quite a few questions on that. But the one thing that typically tends to be missing is looking at androgen receptors, so testosterone. Cancer likes to use these backdoor pathways to thrive. And so with triple negative breast cancer, if that's not something that's being addressed in your situation, there are more so pharmaceutical options that can be used there, Lupron and abiraterone. There's a lot of research also around PD-L1. So this is a particular protein that would allow patients to have more options for specific checkpoint inhibitors. One of the most common checkpoint inhibitors is Keytruda, and I'm sure a lot of people may be rolling their eyes at that. But when you're dealing with this particular kind of diagnosis, sometimes it's important to consider any and all options. So I hope that helps a little bit in just understanding that even though there aren't specific tumor markers for this, there are specific receptors, different mutations that can be looked at in the blood or with tissue sampling or tissue assays that we can assess for these patients. Triple negative breast cancers are actually more likely to respond to immunotherapies versus a more hormone positive breast cancer. And so because of this, it opens the doors for, different forms of immunotherapy. There's actually some interesting research in 2023 looking at GPX4 inhibition, and I'm not trying to go above everybody's head there. What that really is a pathway in how cancer cells has the inhibition to not only induce tumor ferroptosis, and if you know my colleague, Dr. Nathan Goodyear, he goes into great detail about the particular mechanisms of ferroptosis. But this is a very crucial mechanism in targeting very difficult to treat cancers. And high-dose IV vitamin C is one of those therapies that can do that. IV artesunate is another therapy that can do that. Quite a few years ago, there was actually a lot of research around copper. Copper serves as a cofactor for a host of what are called metalloenzymes. Again, big words here, but what these do is they contribute to malignant progression. So there is oral bioavailable chelation that can be used. So in these patients, it's really important to test for their copper levels, their ceruloplasmin levels, and their zinc levels, looking at that balance there. Pretty significant studies showing that it increases the survival benefit in these patients. A few more things on triple negative breast cancer. Both studies in 2020 where they were looking at Coriolis versicolor, which is turkey tail mushroom. This is a profound medicinal mushroom, and I'm not talking about the psychedelic kinds. Medicinal mushrooms in the fact that supporting the immune system. What these do is they inhibit crosstalk, meaning how the cells are communicating together between triple negative breast cancer cells. This allows for inhibition of angiogenesis. We just talked about some of these pathways, EGFR, VEGF. So if we can use specific therapies to inhibit that blood vessel formation, it's cutting off the cancer's blood supply. Another study in 2020, interestingly was looking at the use of IV curcumin in addition to paclitaxel. And what they found was that there were versus just paclitaxel alone, when they included IV curcumin, the results were superior. They had better overall survival and outcomes compared to the paclitaxel alone. So thank you all for the questions on triple negative breast cancer. I think this particular type deserves a lot of attention and understanding because the treatment options tend to be quite narrow or limited when patients are diagnosed with this. This is a question from Yvonne in Florida, a former patient. Hello, Yvonne, missing you. She says, as an aftercare patient, I have a list of treatments that are all very helpful in my healing journey. What are your top 3 treatments that you see being the most effective out there for someone who is trying to stay within their budget? Great question, Yvonne. I appreciate that so much. Only for so many reasons. Out-of-pocket treatment can significantly add up. So I don't know if I can narrow this down to just 3. I'm going to try, but I'm going to start with some really inexpensive things that can be done. When it comes to prevention or long-term maintenance of any kind, we have to focus on diet and the metabolic issues that happen with that. If you've heard me speak before, I've talked about the dysfunction within the mitochondria, and that's not talking. That's really referring to the metabolic rate within the cells and the dysfunction that's happening there. And diet, following an anti-inflammatory or a more appropriate diet, depending on what cancer type you have, is crazy important. If we're talking about narrowing treatments down with a budget, I think vitamin D is the first thing that comes to mind, and that seems really simple. But vitamin D is profound at modulating the immune system. Optimizing those levels for patients, for anyone dealing with a cancer diagnosis, is absolutely essential. When you take a deep dive into the literature, we find across the board that it reduces metastatic burden. It enhances response to therapy. And so if patients are coming in with low vitamin D levels, that's less ideal. So we work really hard to optimize that. When it comes to more injection therapies, if you're really trying to narrow things in, high-dose IV vitamin C would be something that I would prioritize there, as well as mistletoe injections. And if you know me, you know that I've talked a lot about mistletoe. It's one of my favorite integrative cancer therapies. When it comes to supplementation, and I'm trying to give everyone a variety of things because you're talking to an integrative cancer physician, I can't just pick 3. So here's a few of my favorite additional supplements. For breast cancer, hanakiol, which comes from magnolia. This particular supplement can be, especially for triple negative, but all different breast cancer types, it helps to reset certain liver metabolism pathways that could be unhealthy, but it also inhibits what is called the epithelial to mesenchymal transition. That is a long word for metastatic spread. Epithelial to mesenchymal transition, what that means is an epithelial cell is immobile. When it translates over to a mesenchymal cell, that means it's mobile. And so these cells are typically immobile and can become mobile. That leads to spread of disease. So hanakiol is one of my top favorite supplements for breast cancer for patients. Second would be melatonin. For so many reasons. Melatonin is a potent anti-cancer, anti-inflammatory. It has the additional benefit of being a natural aromatase inhibitor. When we're talking about breast cancer, hormone blockers or aromatase inhibitors are there purposefully to block the formation of testosterone and its conversion to estrogen. So we have a slew of benefits, and even at high doses, there are studies also for melatonin supporting bone health as well. So many patients that are going on hormone blockers have a big concern about their bone health. Melatonin is a great addition to that particular piece. There's also a lot of studies around melatonin for bone mets as well. I've already talked about vitamin D, and so I hope that helps. My top 3 supplements: vitamin D, hanakiol, melatonin. Okay, let me switch over to a live question here. This is a question from Melissa. What are your thoughts on fasting, specifically water or juice fasting? Should you take targeted meds, supplements, or other therapies while fasting? Wow, that's a great question. So as far as fasting goes, there's a lot out there. There's a lot of different information out there: water fasting, juice fasting, intermittent fasting. I do think that juice fasting should be taken with caution. Even if you're using organic juices, depending on what you're doing, you could be walking yourself into a glyphosate soup. And what I mean by that is, a lot of vegetables that are kind of covered in glyphosate. And so I'm probably getting a lot of eye rolls for that, but maybe not so ideal, and pesticides as well. So juice fasting is not my go-to for the majority of patients, at least initially. I think water fasting has a lot of benefit. I would encourage that to be done with a healthcare provider and walking you through that, especially if patients have any blood sugar issues and things like that. What I would prefer, and I think is quite beneficial, is intermittent fasting. And that's something that can easily be included into not just breast cancer patients, but any patient's regimen. And there are so many ways to go about that, different time frames. A lot of research kind of stems around a 13 to 16 hour window of fasting. So kind of trimming down your eating window to about 8 hours. And depending on where you are metabolically, that could be done daily. It could be something that you include several times per week. There's also research supporting that as well. So great question, Melissa. Thank you for that. I'm heading back over to the screen here. I had quite a few questions about HER2 status. Can you explain what that means? This is a question from Meg in Iowa. I hope it's getting warmer up there in Iowa for you, Meg. We're dealing with weather in the 70s here, which for Arizonians is sort of cold, but it's okay. So HER2, super important. When we talk about breast cancer, there are different receptors: estrogen receptor positive, progesterone receptor, positive or negative, progesterone receptor positive or negative, or HER2 positive or negative. These are proteins that are expressed on the receptors of the breast cancer cells. And so what HER2 really means when this protein is expressed, it comes from a class of what are called ERBB. And again, I'm not trying to bore you with all the kind of the big terms there, but there's a class of ERBB receptors. HER2 happens to be one of those. And this class of receptors leads to angiogenesis, new blood vessel formation, and proliferation. So what this means, if someone has a HER2 positive status, it can lead to a unfortunately more aggressive disease process, and it can also increase the risk for recurrence in these patients. The catch-22 here, or the advantage, if you will, if we want to think about this, the glass half full, it has more options for targeted therapies like Herceptin and HER2. So, with that status, again, it leads to typically more aggressive breast cancer types, as well as an increased risk for recurrence. One pointer I can give you there is that with HER2 positive signaling, a supplement that can help with that is quercetin. It can actually reduce the HER2 signaling, thus reducing EGFR activity, which is upregulated by that HER2 expression. EGFR activity leads to increased angiogenesis. So quercetin can help in those situations. It's also great anti-inflammatory, as well as having some natural aromatase inhibiting activity as well. Okay, let me see if we have any more live questions. Oh, great follow-up question from Susan. She says, how much melatonin? Great question. Oh, few people. Jay, a lot of people want to know how much melatonin. So definitely don't drive on your first dose of melatonin if you're taking high doses. So we use IV melatonin in our clinic, but orally speaking, if you're taking this, a lot of the research initially had stated 20 milligrams. We're now finding that you can do quite high doses with melatonin. And so patients can work this into their routine. Some people might do just fine with 120 milligrams, but you can work your way upwards of 300. I would not recommend doing that on your own. I do think that should be under the supervision of a physician. Again, you can use quite high doses, and that's all per the literature. Oops. Ooh, hopefully the producers don't get mad at me. I'm knocking the microphone out of the way. All right. Okay. I just stopped letrozole. This is a question from Susan in Wisconsin. I just stopped letrozole, which is a aromatase inhibitor, after 9 years and 7 months, per her oncologist's recommendation. What can I do to prevent recurrence and metastasis? Really good question. Well, first of all, I would say don't drop off on following up and monitoring your progress. But there's a few things that I think should be considered here. And there's a second part to Susan's question. And is transdermal bioidentical hormone replacement safe? I can't wait to answer that. So as far as preventing recurrence and metastasis, obviously, there's a lot involved in this question, and I'm going to talk about prevention in a minute here. But I think it's important to assess your liver metabolism pathways. So there are specific tests that can be done out there, urine hormone testing, that can assess how your body's breaking down any residual hormones. So I think that would be a great place to start. Checking inflammatory markers. So there are some specific simple blood tests that can be drawn. LDH, high sensitivity C-reactive protein, erythrocyte sedimentation rate. All three of these, cancer is a process of inflammation, among many other things. But if you are monitoring yourself, these are really important markers that should be included in monitoring any potential recurrence. As well as preventing metastasis. I think we spoke about the hinocuol earlier. I think getting on something like that would be absolutely essential. But we're going to talk about some other preventative measures in another question I had from someone. So I'll get back to that fully for you, Susan. I really want to touch base on the second question that you asked. Transdermal bioidentical hormone replacement, is it safe? So post breast cancer diagnosis, I'm going to say a big no to that. There are very, very rare occasions in which I think very low doses could be appropriate in the right circumstance with proper screening. There's a lot of research showing that bioidentical hormones or hormone replacement therapy can significantly increase someone's risk for developing any hormonally driven cancer process. Quite a few years ago, I think back in 2018, the studies came out. They were looking at Biest, which is a combination of estradiol and estriol. Can be done transdermally, through troches, vaginally. What they found was, yes, it did increase the risk for developing hormonally driven cancers. But when they included progesterone on top of the estrogen replacement, it substantially increased the risk for developing hormonally driven cancers. I can say anecdotally, I have seen, not in myself, but in clinical practice, there are many correlations when patients are started on hormone replacement therapy. It goes unchecked. They're not monitoring their metabolic pathways, their liver metabolism pathways, and quite a few months later, a lump pops up. I'm going to have more on that later, so do stay tuned. I plan on doing a webinar in the near future here on hormone replacement therapy and its risk benefits, all of those things. But if someone has a breast cancer diagnosis, it's really a no-go for me in recommending that patients do hormone replacement therapy. Again, certain situations could potentially do small doses of estriol, potentially. Okay. A question here from Rebecca. She says, what do you recommend for aromatase inhibitors and other causes of hot flashes and night sweats? Yes. So, right. Many patients are put on aromatase inhibitors, anastrozole, letrozole, Femara. So these medications shut down the body's ability to process or create hormones. And so with that, once we have hormone depletion, what we see is basically all of the symptoms that come along with menopause. And some patients have already been through that process, might be going through that again. Hot flashes come along with that, night sweats, potentially depression, heart palpitations. Specifically for hot flashes and night sweats, I have seen higher doses of black cohosh and vitamin E. Vitamin E is great for kind of modulating that vasodilatory effect. I also think, simply put, cutting back on foods that are more vasodilatory. So wine, alcohol, foods that are more spicy, caffeine, anything like that. Okay. Since we were just talking about prevention, I want to address this question from Vanessa in Tennessee. She said, preventative care for breast cancer. We could probably have a whole series of podcasts on this. If anyone knows me, my colleagues, my patients, I'm always talking about preventative care for breast cancer. One day, I think we need to have just a clinic just for that. So the first thing I want to say about this is physical activity. If you look at the studies, exercise across the board is essential for patients. But with physical activity, even 30 minutes, 3 to 4 days a week can reduce breast cancer mortality by 40%. That's a staggering statistic. So what I'm trying to say is move your body. Prevention is crucial, right? Once a patient is in remission, to prevent the activation of senescent or what are called daughter stem cells. And so we're talking about this physical activity, but if a patient has undergone the standard of care or even integrative therapies, something that needs to be addressed is digestive function, detoxification pathways, and hormone balance. If those three things, in my opinion, aren't addressed, it's really difficult for patients to have success with prevention. So fixing the gut. When I went through naturopathic medical school, on one of my first weeks there, one of my mentors, Dr. Louise Edwards, she said, when in doubt, treat the hole in the middle. And that never rings more true when it comes to prevention, and not just with breast cancer, but health or chronic illness of any kind. Our 75 to 85% of our immune system resides in the gut. We have to address that particular piece. If your body's not detoxifying properly, and that's not just with toxins, that's getting rid of any excess hormones. So looking again at those liver metabolic pathways. I've talked about vitamin D already. Optimizing your vitamin D levels, this lack of calcium absorption, vitamin D and K2 lack of all of these can promote METs to the bones. Right. And so if you're in a place where you're looking for prevention, especially for preventing more advanced states, simple things like that can be very helpful. Continuing dietary interventions, so talking about digestive health, but once you've received a clean bill of health, I hope that's the case for many of you, you need to continue dietary interventions. Going back to, I'm not saying this is anyone out there, but if you kind of revert back to pizza and beer for dinner, and ice cream for breakfast, that's not a recipe for health. You have to maintain those recommendations from a dietary perspective. Lifestyle therapies. I think when it comes to prevention, there's such a huge need for the field of addressing the mental emotional piece with patients. And if, I've heard many times, it's really difficult for patients to heal in the environment in which they got sick, whether that's a dysfunctional home, whether that's a dysfunctional relationship with food, alcohol, whatever it might be. And so if that mental emotional piece or those lifestyle factors aren't addressed, it's going to be set patients up for potential for recurrence, in my opinion. So addressing all of these things. And these are, if you want to look up naturopathic principles, we don't have time to talk about that today. It's restoring the foundation for health. Okay. Wow, we have a lot of questions. I am so appreciative of all of you. Let me see here. This is a question about from Deanna. Do you know the difference in the risk of using BHRT when using a Dutch test? So a Dutch test is a dried urine hormone testing, not blood labs, using low dose transdermals, not pellets, patches, or oral. Deanna, I'm not sure if I understand the exact question. Do you know the difference? I'm going to come back to this because maybe it's worded. Deanna, can you reword your question for me? Okay. I think I know what she's saying, but I don't want to confuse it. Okay. Great question. So when everyone sent in their questions, I tried to compile these so I could address as many of you as possible. This is a question from Mary in California. Should I still get a needle biopsy for a growth seen on a mammogram if I have a negative blood test with the RGCC or grease test, concerned about breaking the encapsulation? Mary, I hear you there. Biopsies are, if there is a suspicious lesion seen, biopsies are a slippery slope, right? Because anytime you introduce a needle, same thing with surgery, you do have potential for seeding. However, it's really essential when it comes to a diagnosis for patients to have a biopsy. It gives us so much information on the cell type, how we can best treat this, how we can approach this in the most precise and specific way. So I understand the hesitation there, but I really think if there is a suspicious finding on the mammogram, I think it's important. I don't want to go too much into this about the RGCC grease test. What I will say briefly is it's not a test I use a lot. I think there's a little bit of controversy around it. There are, however, other screening tests looking at circulating free cell DNA that I think might be more appropriate than the grease test. There is, am I allowed to say names? I don't know. There is a test from Gallery that is one of the first available early cancer detection screening options. So I would say look into that. I wouldn't rely too heavily on the RGCC test, especially if this isn't a known diagnosis. And also that test is kind of expensive. But if something's seen on mammogram, I would go for more of a early screening test. As the last thing I have to say about this, if a lesion is still fully encapsulated, if it is DCIS, meaning it hasn't broken through the basement membrane, very likely you're not going to pick up any circulating tumor DNA. Okay. All right. One thing I will say, oh, great. Okay. Deanna got back to me. I'm hearing. I will get right back to that. Really quickly, when it comes to biopsies, there are things that patients can do around them. They can provide us as clinicians really essential information. High-dose IV vitamin C can be very protective around that biopsy. Things like modified citrus pectin. I'm not going to give doses, but I think that's something you can do some research on that can help bind any seeding cancer cells. So I hope that helps, Mary. Okay, let me get back to Deanna. Deanna said, you said a hard no on BHRT. I was trying to delineate how hormone replacement therapy is delivered, on which type, pellets, transdermals, etc., how to monitor. So, I said the hard no on hormone replacement therapy, especially if someone has had a breast cancer diagnosis or what I would consider a significant family history. I think in those situations, patients should really run far away from hormone replacement therapy. if someone, if you're using the Dutch test, someone has any kind of hormone replacement therapy, whether it's pellets, transdermal, troches, vaginal, PO, and they have a very low risk, I don't have so much a problem with that, but I think they do need to be monitored. And I think the Dutch test can be very helpful in monitoring those patients more appropriately. I hope that helps. Yes, versus the blood. We really shouldn't be seeing high markers of hormones in the blood. That means they're just circulating. They're not really on the receptors being absorbed. Okay. All right. There were quite a few questions on radiation and breast cancer. What are good alternatives to radiation? I don't know if there's good alternatives to radiation. That's kind of a whole category in itself. What I will say about radiation, and this was a question from Christine in Colorado, just kind of asking about what are good alternatives there. What I will say, if patients have a BRCA mutation, BRCA mutations, they reduce a patient's ability to repair DNA. Radiation is a known carcinogen that breaks these bonds within the DNA. They have a really hard time repairing, so it damages the tissue. It creates inflammation within the local tissue in that tumor microenvironment. And if you have a significantly reduced ability to repair that DNA, aka with a BRCA mutation, or a lot of issues with MTHFR, which are also very concerning for me in patients with breast cancer, I would probably avoid radiation. I'm not saying that everybody should do that. If you are going to receive radiation and you have a BRCA mutation, you need a lot of support on board to protect your healthy tissue. I can't say that there are alternatives to radiation, right? There are other heat therapies that can be very appropriate and very successful, like hyperthermia. And I have another person asking a question about hyperthermia, so I will talk about that in a minute. And stay tuned, because I know Dr. Goodyear is going to be doing a webinar soon on hyperthermia and all of the mechanisms, which is an incredibly profound form of immunotherapy. Okay. There is a question from Cynthia in Ohio. Hi, Mom. How long after a mastectomy do you have to take hormone blockers? This is a really big question. A lot of patients ask this. There's a lot of variability here. There's a lot of factors that come into place. The first thing I think about is, what is your estrogen receptor positive percentage? How well did someone respond to maybe their standard of care or their integrative cancer treatment? When you look at the research and the reduced risk for recurrence with the standard of care, 5 to 10 years. I think that if you take into account a lot of other variables, if you address the root cause, the underlying root causes, you're working on prevention, you can potentially reduce those hormone blockers, maybe 1 to 3 years. So again, that's really variable. It's a great question. It comes across my desk all of the time. Okay. Let me see if there's any other live ones. This is a question from, I don't know if it's Eileen or Eileen. Sorry if I'm butchering your name. It's a pretty name. What does one do if they are not able to take any of the aromatase inhibitor drugs? I'm assuming you mean lack of tolerance to them, which is understandable because they can come with a slew of concerns. So Eileen, if you are unable to respond to hormone blockers, I think it would be best to load up as much as possible that you can on other natural forms of aromatase inhibitors. Grapeseed extract, melatonin, quercetin, these are all really supportive here. Okay. I know this one's going to get everybody jazzed. Ivermectin, right? This is a question from Jennifer in Colorado. Go Rockies. How is that baseball team doing this year? It's not even baseball season, is it? That's okay. Is ivermectin a good medicine to take for breast cancer? Yeah. There's a lot of studies, and interestingly, studies that go back to 2016, probably even later than that. There was a 2016 study showing that ivermectin had the ability to inhibit the proliferation of breast cancer cells. Heck yeah. Ivermectin also has a lot of other mechanisms of action. Powerful anti-tumor effects, includes, again, the proliferation of these cells, can help reduce metastasis and anti-angiogenic activity. Great question. Love that you asked it. It also, I'm going to get a little nerdy here, has the ability to inhibit certain pathways, the PAC1 pathway, as well as mTOR. mTOR is a beast. We see this a lot in glioblastomas, which are notoriously difficult to treat. But mTOR is this pathway that just leads to inflammatory pathways and proliferation. So ivermectin is a mTOR blockade. It blocks that. That's amazing. So thank you for that question. I'm a big ivermectin fan. I know Dr. Goodyear is too. Okay. Okay. Hi, Jeff. Great question. What is your position on hyperbarics for healing of reconstruction sites? I'm assuming you're saying reconstruction of breast, whether that's with implants or with a fat reconstruction or damaged radiation sites. I'm all about it. We use hyperbaric oxygen in our clinic for a lot of things, for tissue healing, for reducing infection, for enhancing the effects of low-dose chemotherapy, for stimulating the immune system. Hyperbaric oxygen has the ability to flood the tissue with 8 to 10 times the concentration of oxygen. It's incredibly powerful. When we talk about the main mechanisms of, I know you're asking about wound healing, I'll get there, I promise. But when we're talking about the mechanisms of cancer, they utilize what's called the Warburg effect. They live in a hypoxic environment. They love it. And so hyperbaric oxygen is reversing that. It's flooding the tissue with oxygen. It's displacing carbon dioxide. And so that is what we need when it comes to making these cells vulnerable to reversing those metabolic effects. When it comes to tissue healing, I think it's absolutely wonderful for that. I also think topical ozone can be very helpful for wound healing as well. Great question. Okay. There were a few questions. I'm just going off of memory here. There were a few questions about mammograms and screening and, what is the bet when a patient is maybe in a state of remission or in surveillance or monitoring, what about mammograms, right? Well, there's a lot of research around mammograms, and it's been the standard of care screening tool for a very long time. It unfortunately can miss a significant amount, 10 to 30% of breast lesions that are actually palpable on self-examination. So what I would say when it comes to screening, monitoring, patients might get some pushback from their standard of care physicians, but there are other tools out there. There's a particular type of ultrasound called sonosine, more like a 3D ultrasound that has the ability to actually detect more abnormal tissue than mammograms do. What's unfortunate about mammograms is we have two different types: screening and diagnostic. Screening is more so, okay, you're going in for your annual, and they just do 2 quick views. That could miss so much. I've had $1 for all the patients that said, well, I went in for my screening mammogram, and then 6 months later, I developed a lump. A, it's radiation, could potentially lead to that diagnosis. B, they're only doing a few views, so it could potentially be missing vital tissue. Also, okay, A, B, C, D, E, F, G, I've got a lot of points here. Mammograms, if a patient has implants, dense breast tissue, so much can be missed on a mammogram. Ultrasound, or the sonosine, actually has the ability to kind of, because of the waves, has the ability to detect that abnormal tissue even in dense breast. So I did want to address that. There were quite a few questions about that on the form. So I appreciate all the patients, or not patients, beautiful people out there sending those questions in. Okay. Let's see here. Okay, question from Janet. Is the CA2729 a good test to monitor a person after treatment? This is my first time interacting with you. Hi. Do you monitor patients like me? Well, Janet, I would love to meet you. Let's talk about tumor markers. So tumor markers, and Janet's asking specifically about CA2729. Tumor markers are proteins that are expressed on tumor cells. There are many different kinds. With breast cancer, CA2729, CA15-3, CEA. Some will use CA19-9, which is more so for pancreatic cancer and other GI cancers. They're nonspecific. However, if they are there, if they are present at diagnosis, they can be useful at monitoring a response to therapy or used for monitoring long-term metabolic activity, things like that. Tumor markers, ebb and flow. With treatment, we see this all the time in our clinic when there is tumor lysis or tumor die-off, especially post low-dose chemotherapy. We can actually see a spike in those. So I would not use them as a sole, blood test to really monitor a response to someone. I really think you can use it in the context, using that with circulating tumor DNA, imaging, other labs, inflammatory markers, and taking that all into consideration. So I hope that helps. You're giving me all these ideas. I got to do a whole webinar on just tumor markers. Good stuff. Good questions out there. Melissa. Hi, Melissa. I think you've asked a few questions. I love your questions. What are your thoughts on febendazole in addition to ivermectin? Great question. Both of these there's a lot of riffraff, a lot of studies around these antiparasitics for not just breast cancer, but for cancer across the board, repurposed medications. We see not just febendazole, ivermectin, mebendazole, all have a lot of these similar pathways. Febendazole can kind of inhibit stem cell growth and proliferation. So really important. I think when it comes to these particular repurposed medications that you're asking about, I know a lot of people are probably doing them on their own, but I would recommend doing it with the guidance of a licensed practitioner and making sure that you're monitoring your liver enzymes. Alternating them can be another great way to do that. So there is a lot of good research for that and use for it. Okay. Let me see here. Ooh, great question. This is one of my dear former patients. Hi, Tara, all the way back in New England. She's just asking about tamoxifen and breast implant risks. Oh, I cannot wait to dive into this, but just given our time today, I'm briefly going to talk about it. When it comes to tamoxifen, and so I'm gonna split this up. Oop, there goes my microphone. When it comes to tamoxifen, there's a lot to be said about it. There are certain patients that could have a greater benefit for it, especially if there is a estrogen receptor positive status and there are a perimenopausal or premenopausal status. That being said, it does come with its own very large encyclopedia of undesirable side effects. What I will say is that when I've had patients that are on tamoxifen, I do prefer lower doses if it is necessary. There was a really, really cool study back in 2019 talking about baby TAM, which is a quarter of the dose of tamoxifen. What they found in this study was that patients were able to reduce the time frame of using tamoxifen to 3 years versus 5, and taking just a quarter of the dose. And it significantly reduced the side effects, and they had the same outcomes for reduced risk for recurrence. If you're asking about risks with tamoxifen, the biggest risk there, and I talk about this with my oncology students, tamoxifen dumps excess estrogen into the uterus. It is a SERM, a selective estrogen receptor modulator. Very different than aromatase inhibitors. So what it does is it's not fully suppressing hormones. And so it can dump those into other places. So yes, it can reduce your risk for breast cancer, but potentially highlight or increase your risk for developing endometrial uterine cancer. I can't say it's my favorite, but don't tell that to the standard of care world. When it comes to breast implants, I want to unpack this so bad. Breast implants are absolutely, in my opinion, they're an increase if patients have them, or if someone has, regardless of the purpose, it's a foreign object. It's a cause for potential autoimmunity, immune dysfunction. I think if they're not necessary, I wouldn't recommend patients get them. The biggest concern that I have is typically when patients have a mastectomy. So if we're talking about reconstruction, when patients have a mastectomy, they immediately put the breast implants in. So now we have a suppressed immune system from surgery. We have an inflammatory environment, a place where the body needs to heal, and we're putting a foreign object into the body. I have seen this in patients where they have developed, unfortunately, breast cancer down the line. And I know I'm probably creating a lot of panic for people out there. I'm so sorry, but this is anecdotal clinical observations where they have developed breast cancer on the capsule of the implant. What I will say about this is that if you must have a reconstruction, there are so many other ways to go about it. You can use your fat. There are amazing surgeons out there that, if they're not willing to do that, go get another opinion. I'm going to pause there on that because I, in the near future, plan on doing a whole webinar on breast implants and the risks with that, talking about the inflammation, the immune dysfunction, the autoimmunity, blah, 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 blah. I can't wait. I hope all of you are there to listen to it. I'm going to unpack that for you soon. Okay. I think we have about a few more minutes here. Let me go back this way. Ooh, great question from Deanna again. I've got a few fans. Some of the same people asking questions. As far as the sonosine, the breast ultrasound, does it recognize calcifications? Yes, it does. What is typically the downside to ultrasound versus mammogram? So ultrasounds, 2D ultrasound, I would say, is not a very effective way to assess for breast lesions. What you want is something more like the sonosine or a 3D ultrasound, because you actually get a better splay, a deeper splay and a deeper image to be able to find those calcifications and the size of the lesion. A 2D is kind of like, it's cutting you off. You're really not going to see much. Ultrasound can also detect very clearly a cyst versus a solid mass or vasculature, right? Mammograms are really only looking for densities, not really looking for vascular involvement. So that's a little extra piece there. Hi, Helen. Great question. I think I know who this is. If you remember me, hi. Are thermography and pre-nuvo scans appropriate screening tools or follow-ups for monitoring? Thermography is so controversial. In my clinical opinion, I do not think it is appropriate for screening patients for breast cancer. That being said, If a breast comes up hot on a thermography scan, yes, you need to look into that, right? I wouldn't ignore it, but I don't think that there's a lot of sensitivity when it comes to thermography. Can it let you know that something's brewing? Absolutely. But for screening, I don't think that's appropriate. When it comes to pre-nuvo, thank you for bringing this up. I'm so sorry I haven't even mentioned this to this point. Pre-nuvo is, it's not fully readily available for everyone, but there are certain areas where you can find that. Pre-nuvo is a newer technology. It's basically a full body MRI, mimicking a PET scan without the radiation. And so when it comes to pre-nuvo, I think that's a more than excellent tool when it comes to screening or monitoring long-term. Unfortunately, it's not insurance based right now, so that would be out of pocket for patients, but excellent form of imaging. Okay. We've got just a few more minutes here. I'm going to go back over here. There's a question from Shirley from Kansas. Help with bone mets with breast cancer. You know, when it comes to bone mets, right, typically we're dealing with a more advanced process. What I can say, I'm going to speak to two specific things here. First of all, bone mets can be healed depending on the amount of damage that's been done to the tissue, right? If it's early bone mets, I've seen them completely resolve. Hyperthermia is a very profound treatment that can be used to penetrate deep into the tissue. It's a natural form of immunotherapy, one of the best indications when it comes to bone mets. I mentioned this earlier as well, melatonin, really helpful at healing the tissue, healing bone mets, again, needing higher doses in that situation. Some patients, depending on where that is, I know I'm going to get a lot of hate out here for this, but things like Zometa and more bisphosphonates, things like that, depending on the damage, could be supportive. We've talked about vitamin D, optimizing those levels as well. Okay. So a question from the UK, and I think we've kind of addressed this. What is the best non-toxic way to monitor progress, shrinkage of tumor? So, you know, with, well, especially when it comes to breast cancer, we haven't talked about this. MRIs. Right. We talked about the pre-nuvo just now, but if you don't have access to that or you're using insurance, when it comes to monitoring the progress or shrinkage, especially if we're looking at the lymph, if it's local, right, looking in the lymph nodes or in just a lesion in the breast, a 3D ultrasound can be helpful, but I think a bilateral breast MRI is an excellent way to monitor progress and tumor shrinkage. This is an interesting question from Elaine in Phoenix, Arizona. I love it here. Have you studied the effects of float therapy on white blood cell counts? I have not, but that sounds really promising and very relaxing. What I can say to counter this point, since I don't have an answer to your question, I bet you that there is research on that, and I can absolutely see how float therapy or float tanks could improve immune function, not only because it's relaxing, but it's great for the mental space. There's a lot of really cool research on forest bathing. What that really means is getting outside and walking in nature, but that's what they put in the research. Forest bathing. They did studies where they drew the blood prior and then after, and what they found was significant increases in white blood cell counts and natural killer cells, both of which we need when we're fighting cancer. So I'm going to go, after we're done here today, thank you, Elaine. You have sparked my interest. I'm going to go look at float tanks and float therapy for increasing white blood cell counts, specifically because when patients are going through treatment, leukopenia, neutrocytopenia, low white blood cells, low neutrophils, happens very frequently. And so any and all tools that can be used to support that are excellent, right? Hyperthermia is great for that. I use astragalus a lot in patients to kind of build their white blood cell counts. But that is a fantastic question. I think I have time for like one more. I see my producer shaking over there, so let me just see what I can do. How do I heal after surgery? This is a question from Liz in Michigan. So when it comes to surgery, right, we don't think about it as immune suppressive. So what I will say is that on the front end of surgery, you should be doing everything that you can to build your nutrient stores. That could be through IV Myers. That could be through just building basic nutrients, vitamin C, vitamin D, vitamin A, vitamin B, right? Because your body's going to burn through those as it's trying to heal and repair. High dose vitamin C, especially if we're talking about breast cancer surgery, very helpful for stimulating the immune system. It's very anti-inflammatory. And you can do all of that on the back end of surgery as well. One other point I would like to make, if at all possible, find you a surgeon that does a non-opioid pain management protocol. Opioids suppress the immune system like crazy. There's also some research showing that it can actually lead to cancer cell proliferation. There are many protocols out there utilizing gabapentin, Celebrex, acetaminophen, and controlling pain very well. So when it comes to the pain management piece and healing, avoiding opioids if possible, or narcotics. Okay. So I know that we've come to the end of our Q&A here on breast cancer. I am so appreciative of everyone's attention. If you'd like to receive a notification or subscribe early for our next webinar, because we are so excited to give everybody information here at Brio-Medical. If you want to watch the replays of past webinars, including this one, good info here tonight, you can visit www.brio-medical.com/resources/webinars/. You can also follow us on social media at Brio-Medical. You can follow me at, my handle is at Dr. LaBant, DRLABANT, for more good information. And stay tuned for next week's webinar. Dr. Goodyear is going to be taking the stage on February 29th, same time, 6:30 p.m. Eastern Standard Time. He's going to be talking about high-dose IV vitamin C. I know that's a topic he is always jazzed about. So bring your questions, and he will see you next Thursday, and I'll see you next time. Thanks so much for tuning in, and I hope everyone has an amazing evening.